So there are many factors so underlying these things. So one is the genetic and also environment in the sense that we discussed before, could be an allergens, whatever the things. So it results in basically airway inflammation. So so there is mainly the lymphocytes. If there is repeated triggers and insult, they have imbalance in their response, so which ultimately causes the bronchospasm. So bronchospasm, so it stimulates the the airway smooth muscle. It can cause it causes bronchospasm, and resulting for these inflammation, secondary inflammation, there is a mucosal edema and exaggerated mucus production. All together it causes airway narrowing. So if the airway get narrowed, and then there will be a increased resistance to airflow. So when the air tubes so get constricted, when they so when the airflow grows, there will be increased resistance, and then so even they get the air, they can't expirate. So there will be a reduced expiratory flow, which leads to hyperinflation. So when there is only the hyperinflation, there was no proper ventilation, no air in and out air, so which causes alveolar hyperventilation. Even though there is a perfusion, blood circulation is there, if there is no ventilation, that causes ventilation perfusion mismatch. Ultimately it causes hypoxia. So the hypoxia itself drives the respiratory center, and the child started to breathe faster because hypoxic. So the child tends to breathe faster. That's the thing that manifests as respiratory distress, increased respiratory rate, so increased recessions. So suprasternal tachycardia, intercostal recessions, subcostal recessions, these are related to hypoxia. When they hypoxic, bronchoconstriction, no airflow, so they want to take more breaths. So resulting that they can have the respiratory alkalosis because of this hyperventilation. Later, when the child breathe, when the child get tired, what happened? He can't. So the child can't work more. So resulting that hypoxemia will be there, but they can't. There'll be more CO2 retention. So we say it's a hypercarbia. So later stage they will have the respiratory acidosis. So respiratory acidosis in an asthmatic child coming with the exacerbation, always it's a real emergency. So it's either severe or life-threatening asthma, you can see respiratory acidosis. What we expect in asthma coming in child, so that is the respiratory alkalosis. So one indication for ventilation in children is respiratory acidosis in an unwell child with asthma. So it is very serious if the child has the respiratory acidosis. Right, this is just regarding some with the pathophysiology underlying disease process. So I just put this slide to understand we are using different type of medications, no? So each medication, what is the mechanism of action? So we give steroid to reduce the inflammation. So it's if we can see this diagram, and also there is the airway smooth muscle. We are giving either inhalers or else the nebulizer, the short acting relievers, that is to relax the airway smooth muscle, and theophylline also act on that. And so Montelukast, so basically I told these T cells and mast cells, they release some histamines, histamines and then leukotrienes. So the Montelukast will act on that receptor only, right? And so there are some biologics as well. So just good to know. So what are these medications doing? And so few words about clinical phenotypes. Since there are many underlying disease process, so common is the allergic asthma most of the time. That is so most of the children or most of the people have the allergic asthma is the most common phenotype, because they may have the personal history of atopy, kind of like allergic rhinitis, eczema. There will be a family history of asthma, and also when we treat with this relievers, they will immediately respond to these bronchodilators, that is the phenotypes. One is the allergic asthma, others are less common and just these non-allergic asthma, cough variant asthma. Late onset asthma is the adult onset asthma. So and asthma with, there are the other less common types are when we usually the asthma, the response to our usual treatment is allergic asthma. Some are drug resistant asthma or severe asthma. In that case we go in detail and study about asthma, so study about their phenotype, that is not the allergic asthma. So in that case our treatment is going differently, rather than with the the usual traditional management, they will be directed into the kind of like biologics, so which are in in development. So how do we diagnose asthma? So child coming in the cough, some distress, and then so we just not just the nebulizers, so we have to have a strategy, or we should have a proper before we diagnose asthma. So always history taking is very important. So history, we have to ask, if we are thinking of asthma, we have to from the history we have to get little more information to say whether to look for whether it is an asthma or not. So always history is very, very important. So anyway, coming with the cough, we should ask about these core clinical symptoms. As I said before, the core clinical symptoms needs asking. And other one is the pattern of the symptoms, the diurnal variability. So variable over time and intensity. Usually they'll have the early morning and then so towards the evening. That is the diurnal variation or variation over the time. Sometimes it triggers with the like cold weather, right? And so these symptoms, so presence of triggers, so we talked about triggers before, kind of allergen, exercise, viral infection. So presence of triggers, say if one so they have, so one child, so they have pet at home, but he's not having, after by exposing to that cat or dog, he is not getting these respiratory symptoms worsening, and it doesn't mean it's a trigger for him. So these symptoms should be get worsening, or he should get after getting exposure to the triggers, his symptoms should start or else worsen. Only we are considering that is the trigger for him, right? So so if the child is so other examples, so when the child is exposed to smoke, he didn't get any worsening of symptoms, or he didn't get any cough, then it's not a trigger for him, but it may be a trigger for another one, right? So just presence of triggers, the common triggers, it doesn't mean that he has asthma. It should, his symptoms should worsen with these triggers, or else he has to develop these symptoms because of these triggers, right? And obviously we have to ask the family history of asthma, which is also is a one contributory factor to have asthma, and also on physical examination, so we have to find some scattered V's, right? So with this, with the history, with these clinical symptoms, and also so as much as possible we have to get the confirmed variable expiratory outflow, which is we don't we practically we don't do that. So we do that, but so we give the nebulizers and see it's responding. We are going towards the clinically, but we don't have this objective measurement to say there is a variable expiratory outflow like in developed countries. So